Hi MS1s, welcome to Lecture 8. Please do not hesitate to contact me if you have questions. You can email me, you can post on the Q&A message board on Canvas, you can call my cell phone, you can even come over to my house for a cup of coffee, or you can zoom in on my weekly office hours. So in this lesson we're going to consider the factors that influence preload on the heart, or more accurately, central venous pressure. Recall that central venous pressure is a major force promoting ventricular filling during diastole, and consequently it largely determines end diastolic volume, which, as we've learned from our lessons on the Frank-Starling length tension effect, is a major determinant of stroke volume and pumping performance of the heart. Recall that the heart is actually two pumps arranged side by side. They operate in series, that is, one receives the output of the other. And because the two pumps are connected and form a closed loop, they must pump the same volume of blood. What is delivered to one must be pumped by the other. But is this true? Do the pumps propel the same volume of blood on each heartbeat? Well, if the vessels were rigid steel pipes, the two sides of the heart would certainly have to eject the same stroke volume from beat to beat. But our blood vessels are not rigid steel pipes. The veins are, in fact, highly distensible. And in fact, if they were called upon to relax fully by sympathetic withdrawal, they could hold every last drop of blood in the periphery and venous return would fall to zero. So now let's reconsider that question. Do the two pumps propel the same volume of blood on each heartbeat? Well, from minute to minute, they must indeed pump the same volume. But from beat to beat, their outputs can vary considerably due to the fact that the venous reservoir is highly distensible and its capacity is regulated by sympathetic tone and influenced by gravity. So how is the output of the left heart normally matched to the output of the right heart? How is cardiac output matched to venous return? It all comes down to preload and the Frank-Starling length tension effect. If on one beat venous return were to increase, there would be an increase in preload, and this would be reflected as an increase in central venous pressure. This would dilate the ventricle, which would fill with a greater volume of blood during diastole, and the stroke volume would increase in proportion following the Frank-Starling length tension relationship, as we have seen. So this is how cardiac output is matched to venous return over the course of several beats. So the question now becomes, what determines the preload? That is the topic of today's lesson, and here are your learning outcomes. The first place to start is to consider the volume of blood that is held in the vasculature, because that is going to affect the central venous pressure. And remember that the distribution of fluid water in the cardiovascular system follows the so-called 60-40-20 rule. The 60 refers to the fact that about 60% of the body weight is water, and that 40% of the body weight is water held within the cells, the so-called intracellular fluid, and that 20% of the body weight is distributed outside the cell as extracellular fluid. And if we take a closer look at this ECF, we see that 3/4 of it represents interstitial fluid in between the cells, and about 1/4 of it represents circulating blood plasma. Not blood, but plasma. So about 3.5 liters of plasma circulates through the cardiovascular system. And this is the parameter that will be very important in determining central venous pressure, the so-called vascular volume. An even more important term is called the effective circulating volume, or the effective vascular volume. And this is the portion of the ECF that is within the vascular system and is effectively perfusing the tissue. And effective perfusion of the tissues requires a properly functioned pump, in other words, cardiac output. It requires enough volume within the vasculature to effectively perfuse all the tissues, and it requires a peripheral resistance for the pump to develop arterial perfusion pressure. So it's not surprising that the body deploys multiple overlapping feedback systems to monitor and regulate intra-arterial volume and pressure. In fact, the effective vascular volume is the volume that is sensed by our arterial baroreceptors, our pressure receptors. And it's the volume that is regulated by the kidneys. We're going to hear more about this in the renal physiology module. Recall that there's about 5.5 liters of blood circulating in our vasculature, and that 2/3 of it is held within the systemic veins and venules. And so the veins are called the venous reservoir because the majority of the body's blood is held within them. The extracellular fluid volume, and therefore the blood volume, reflects a balance between fluid intake and urine output. Fluid intake is regulated by the thirst centers of the brain in the hypothalamus, and this in turn is regulated by the osmoreceptors, which we'll talk about more. Urine output is regulated primarily by 3 hormones: antidiuretic hormone, atrial natriuretic peptides, and aldosterone. These details will be fully considered in the renal physiology module to come in Block 2. Now, we mentioned that the veins hold 2/3 of the body's blood volume. And an important feature of this venous reservoir is that its capacity is highly regulated by the sympathetic nervous system. So the venous volume is continuously adjusted by the sympathetic nervous system, and that displaces blood from the veins, squeezing it back to the thoracic compartment where it is available to fill the heart and control preload and blood pressure. Let's consider how that is achieved. The veins are beautifully designed to function as an adjustable venous reservoir. They have an extremely high capacitance. They are highly distensible. Capacitance is just a term that describes the ability of a vessel to expand in response to a given increase in transmural pressure. So as the pressure within the vein goes up, the volume goes up, and this is the distensibility, or a more accurate term, capacitance. Here we can illustrate the difference in capacitance of a vein and an artery. Notice that for a given change in transmural pressure, in other words, the distending pressure across the wall of the vessel, for a given change, the vein increases its volume, it distends very easily. Here is the normal operating pressure range of a vein, somewhere between 0 and 10 millimeters mercury. So in this range, small changes in transmural pressure, venous pressure, result in large changes in venous volume. The vein distends easily when subjected to an increase in pressure. In contrast, the artery is elastic, but it is not highly distensible. It normally operates at a high transmural pressure, and changes in that transmural pressure do not result in a large change in arterial capacitance. A critically important feature of the vein is that its capacitance, its distensibility, can be regulated by sympathetic venoconstrictor fiber input. So in response to sympathetic outflow, sympathetic venoconstrictor fibers instruct the smooth muscle coat surrounding the vein to contract. And this contraction causes the capacitance of the vein to decrease. Imagine wrapping your hands around the vein and squeezing. The blood would be displaced from the peripheral veins back to the thoracic compartment where that blood is available to fill the heart preload. The capacitance of the veins is powerfully regulated by sympathetic nerve input, whereas the artery is not. So in our future discussions, let's distinguish this by calling this sympathetic venoconstriction. Let me try to illustrate this on this axis, which shows the liters of blood held in the veins. Remember, the total volume of blood in the vasculature is about 5 to 5.5 liters. And recall that the veins hold about 2/3 of the vascular volume. So let's say that the veins hold about 3.5 liters of blood. Under maximal venoconstriction, the capacity of the veins will drop from 3.5 liters down to about 1 liter. On the other hand, if sympathetic drive is completely withdrawn, in other words, maximal venodilation, the capacity of the veins will increase to about 7 liters of blood. It's important to note that this is well above the total volume of blood in the vasculature. So we're left to conclude that if instructed to do so, the veins can hold on to every drop of blood in the body and not allow any back to the heart. So this tells us that the veins, under the control of the sympathetic nervous system, determine whether the blood is stored in the periphery or returned to the heart. So the veins determine the preload. And because venous return and preload are the major determinants of cardiac output, we can conclude that the output of the heart is determined mainly by the veins and their control by the sympathetic nervous system. Okay, so what in turn determines the sympathetic outflow? Well, that's a large question, and we're going to get to that in a couple lectures. But the sympathetic drive is regulated acutely in large measure by the baroreflexes. In other words, in response to changes in arterial blood pressure. So let's review the effect of venoconstriction on mobilization of blood. In response to sympathetic input, acting through the neurotransmitter norepinephrine on the alpha-1 receptor, the smooth muscle coat of the veins will constrict. This will reduce their capacitance, their ability to hold blood, and they will squeeze down on the blood volume. The pressure will increase, and the peripheral reserve blood will be mobilized back to the thoracic compartment, back to where it can immediately fill the heart. And this will increase ventricular preload and cardiac output. On the other hand, with sympathetic withdrawal, the veins will dilate, the smooth muscle coat will relax, the veins will become more compliant, more capacitant, and now because the veins are expanded, the pressure inside will decrease, and blood will be demobilized and stored in the peripheral veins. This will reduce ventricular preload and cardiac output. So it's clear that the sympathetic nervous system has a dominant effect on venous return and central venous pressure. Let's model that with a ventricular function plot. Recall that at a certain end diastolic volume, the ventricle is capable of developing a certain maximal pressure. If preload is increased during diastole, the ventricle will expand further, and by the length-tension relationship, the ventricle muscle will be able to develop greater tension. Because end diastolic volume will be proportional to the central venous pressure, let's replace that term on the x-axis. And because ventricular pressure development will be proportional to the cardiac output, and in a steady state, the venous return, let's replace that on the axis. These are just proportionalities. Notice that the output of the heart at a given fixed heart rate, if we have a central venous pressure of normal about 2, we'll have a cardiac output of about 5.5. If we have a loss of blood volume, let's suppose we have a nasty accident with a meat cleaver and we hemorrhage out 600 mils of blood, the blood volume and central venous pressure and preload on the heart will decrease, and that will decrease cardiac output. The same effect will be seen if we withdraw sympathetic venoconstrictor tone. The veins will dilate, they will hold more of the blood peripherally, and the preload and cardiac output will decrease. Let's go the other way. If we infuse additional blood into a patient's veins, venous blood volume will increase, central venous pressure will increase, preload on the heart will increase, and cardiac output will also increase. The same effect will be produced by sympathetic venoconstriction. This will clamp down on the peripheral veins, blood will be mobilized to the thoracic compartment where it can fill the heart, central venous pressure will increase, along with preload and cardiac output. Now, why is this important? Well, we will see that central venous pressure fluctuates from beat to beat due to variations in all kinds of things, respiration, posture, exercise, and fortunately, fluctuations in central venous pressure are minimized by the very powerful and rapid action of sympathetic constrictor nerves on the peripheral veins. Central venous pressure will also depend over the long term on blood volume. Let's look at another example at how this can change acutely. Here we are back at our ventricular function curve with a central venous pressure normally at about 2 millimeters mercury, giving us a preload that translates into a cardiac output of about 5.5 liters per minute. Suppose we had sympathetic venoconstriction to the veins alone, acutely. The veins would lose some of their compliance, squeeze down and mobilize blood from the periphery back to the thoracic compartment, and that would increase central venous pressure at the level of the atria. And that would give us more preload, more stretch of the ventricle during end diastolic volume, and a greater cardiac output according to the Frank-Starling length-tension relationship. And if we then superimposed sympathetic stimulation to the heart, remember this is going to increase ventricular contractility, and that will be reflected as an upward shift of the ventricular function curve. So at a central venous pressure of 4.5, sympathetic stimulation of the heart can improve cardiac contractility, a positive inotropic effect, and this will increase cardiac output even further. Let's examine these coordinated responses to hemorrhage. So here we are normal. 2 millimeters mercury on the central venous pressure gives a cardiac output of 5.5 liters per minute. Suppose we have that nasty accident with the meat cleaver. We bleed out a liter, liter and a half of blood. As blood is lost from the vasculature, central venous pressure, preload, and cardiac output drop. Let's say it comes to point B. The loss of cardiac output and blood pressure will activate the baroreflexes. We'll talk about that in detail later. The baroreflexes are activated. This causes an outflow of sympathetic drive, and this will improve the contractility of the heart by direct stimulation of the beta-1 receptors on the working myocardium. So now we'll shift our operation from point B to point C at that reduced central venous pressure. We've restored cardiac output almost to normal. At the same time, however, there will be sympathetic outflow to the veins. and this will constrict the veins, mobilize more blood back to the heart, and improve central venous pressure. This will take us maybe from point C to point D. And any deficit in cardiac output can easily be made up by the simultaneous increase of sympathetic drive on heart rate. Okay? So, the baroreflex acting through the sympathetic nervous system on the veins and the heart have restored cardiac output and arterial perfusion pressure. Okay, so far we've looked at the effect of venomotor tone on preload. There are 4 other important factors determining preload: respiration, gravity, venous valves, and skeletal muscle activity. Let's take a look at those one at a time. First, respiration. Every time we inhale, venous return surges back to the right heart. How does this work? When we inhale, the diaphragm contracts and moves downward inferiorly, and this expands the thoracic cavity. In addition, the external intercostal muscles contract, and this elevates the ribs and expands the thoracic compartment even further. And other muscles cause the central sternum to move anteriorly forward. And all of these muscle contractions surrounding the ribs causes the thoracic compartment to expand, and the pressure within the thoracic compartment decreases. And this is the pressure gradient that draws air into the lungs. When we exhale, the opposite happens. The diaphragm relaxes and moves superiorly. As a consequence, the thoracic compartment contracts, the intrathoracic pressure increases, and this pressure gradient pushes air out of the lungs. So how does this affect venous return? Suppose we place 2 pressure-sensitive catheters, a blue one inside the thorax and a green one inside the peritoneal cavity, the abdominal cavity. The blue pressure transducer monitors the intrathoracic pressure here, and the green pressure sensor measures the intra-abdominal pressure here. Now we ask the subject to inspire, and we see that as the thoracic compartment expands, the pressure drops, and at the same time, as the diaphragm is pushing downward on the abdominal cavity, the intra-abdominal pressure increases. The difference in pressure between the abdominal cavity and the thoracic compartment is the pressure gradient that drives venous return from the lower periphery. And as a consequence, we see blood flow in the vena cava surge back to the thoracic compartment during inspiration. So to summarize, each time we inspire, there is a surge of blood flow back to the thoracic compartment, and this effect is called the abdominothoracic pump. Gravity also has a major effect on venous return. When we lie flat in a supine position, all portions of the vasculature are at the same level and therefore are affected by gravity equally. When we rise out of bed to a standing position, the pressures in all vessels below the heart are increased, whereas the pressures above the heart are decreased. And this is because gravity affects the column of blood within the vessels, and because the veins are highly distensible, small pressure changes can produce large changes in venous volume. And this added hydrostatic pressure can dilate the large veins in the leg and cause what is called peripheral venous pooling. Peripheral venous pooling, as you can see, decreases central venous volume and pressure, which in turn lowers cardiac output and arterial blood pressure. Normally, these changes are compensated within a single heartbeat by the baroreflex. That is, a sudden fall in arterial pressure activates sympathetic venoconstriction, blood is mobilized back to the thoracic compartment. At the same time, sympathetic outflow to the heart increases contractility and heart rate and can normally restore cardiac output. When this compensation does not occur quickly enough, the sudden fall in blood pressure upon standing can cause momentary dizziness, and this is called orthostatic hypotension. We all experience it occasionally. Another factor that affects central venous pressure is venous valves. The large veins have a system of valves which ensure that blood flows only in one direction, towards the heart. And these valves partition the column of blood within the veins into short segments and therefore minimize the effect of gravity on venous return. You can see how this valve operates as a one-way check valve, because if the blood attempts to flow in a retrograde fashion away from the heart, this flap will seal up, preventing retrograde flow. Now, sometimes these valves become leaky, allowing the full hydrostatic column to be exerted on the capillaries, and this leads to an accumulation of excess fluid, edema, in the tissues of the legs and feet. We're going to talk about that later. For the moment, be aware that these leaky valves can allow retrograde flow, dilation of the veins, and can lead to a condition called varicose veins. The last factor that can affect preload is skeletal muscle pump activity. Contraction of the skeletal muscle boosts venous return by intermittently compressing the veins between the contracting muscles. And notice, for this effect to operate efficiently, the venous valves must operate properly so that The blood is milked toward the heart and doesn't leak retrograde back to the periphery. So skeletal muscle activity serves as an auxiliary pump that mobilizes peripheral venous blood back to the thoracic compartment and raises central venous pressure. Considering this, in which of these men will venous pressure in the feet be greater? This man standing or in this man running? In this man, due to prolonged standing and the effect of gravity on the vertical column of blood in the veins, the venous pressure in the feet will be very high, about 90 millimeters mercury. Compare that with this runner. Intermittent contraction of the skeletal muscles will milk the blood out of the periphery back to the thoracic compartment, and the venous pressures in his feet will drop. There is another reason why the venous pressure in this man's feet is much lower. That is because he is breathing rapidly and deeply, and the abdominal thoracic pump is also working to vigorously draw blood back to the thoracic compartment. So both the skeletal muscle pump and the abdominal thoracic pump, the respiratory pump, counter peripheral venous pooling. And I can show you proof of that. Let's perform a little experiment. We have a normal subject, and we're measuring the foot venous pressure with a catheter in blue here as a function of time. And we record a pressure of about 85 when our subject is standing still. We then ask the subject to begin walking. As our subject walks, skeletal muscles in his legs are squeezing down on the large veins, and that is milking the peripheral venous blood back to the thoracic compartment. And notice that it happens in oscillations, which represent each time he contracts his leg muscles. In addition, as he starts to breathe more rapidly, the abdominal thoracic pump is pulling more blood from the periphery into the thorax. When we ask our subject to stop walking and remain standing still, foot venous pressure increases progressively back to about 85 millimeters mercury. Now let's repeat this experiment in a patient that has leaky venous valves, deep venous valve insufficiency in his lower limbs. When we ask our patient, shown in red, to begin walking, we see a much weaker drop in foot venous pressure, and the oscillations aren't nearly as large. And this is because his leaky venous valves fail as one-way check valves. That is, they allow retrograde flow, and even though the skeletal muscles are intermittently compressing these veins, the blood can leak back under the influence of gravity. And that concludes Cardiovascular Lecture 8. Thank you so much for your attention.